Hello, everyone. Thank you so much for joining us, the Scleroderma Foundation Rocky Mountain Chapter's Fall Education Summit. This session is filled with all the things your doctors never told you: sex, drugs, and other taboo topics. And a special thank you to the organizing committee for coming up for this important topic, as well as our esteemed speakers. My name is Tracy Frack, and I have the honor of introducing our speakers today. But before we get started, I want to give you some quick notes about the session. In no way does the Scleroderma Foundation endorse any of the clinical trials, treatments, or slides mentioned in this session. Because of the manifestations and severity of scleroderma, they may vary amongst individuals, and so a personalized medical management approach is essential. Please discuss everything with your individual doctor. This webinar is for educational purposes only. So I'd like to get started by introducing our comedian, Karen Vasquez. She's a mom, writer, graduate student, and is going to give us scleroderma in 60 seconds. She was diagnosed in 1994 with scleroderma. She's been working on scleroderma and chronic disease as an advocate for over 20 years. She's going to share with you with a light approach on how tenacity saved her life more than once. So with that, let me introduce Karen by virtual video.
Hi, my name is Karen Vasquez, and I'm coming to you all the way from Anaheim, California. It's great to be here. I'd like to address the elephant in the room. Yes, my name is Karen, but I use my Karen powers for good. I'll still call your manager, but it'll be nothing but praise and compliments. Who made these fries? These fries are delicious. Where's your chef? You tell your chef that we are coming back to this Red Robin just for these fries. We are lifetime customers now. And our server, Patrick, oh my gosh, he's amazing. He's a peach. You need to give him a raise. So now that we've addressed the elephant in the room, let's talk about scleroderma. I've never really had any signs or symptoms before. I don't have a family history. When I was 18, I was working as a manicurist, and I wanted to get out and see the world, but Carnival Cruises wouldn't hire me, so I joined the Navy. Go big or go home, right? The Navy was pretty amazing. I'll never forget boot camp when I was issued my first uniform. See, we'd been in sweats all week. Oh, but I skipped the important part. You see, I decided to go to boot camp in July in Orlando, Florida. July in Orlando, Florida, it sucks. Not the smart place to go to boot camp, but apparently that's what I decided. So for the first 2 weeks, we're running around in sweats because we had to learn to exercise in, 90-degree humidity. And I'll never forget when they issued my uniform. I finally got it. Get there, and you wouldn't think it was that exciting, but I gotta tell you, I was like Julia Roberts in Pretty Woman. Like, they handed me my dress blues, and I was amazed. Like I never knew that badassery could be so feminine. Oh, it was amazing. So, moving on to my first duty station, I was stationed on the USS Yellowstone, and I worked on the boat deck. I was assigned a small boat, and my job was, so I had this boat. The way my officer in charge explained it is, Karen, when the paint cracks, you're gonna sand it, you're gonna put a coat of primer and 2 coats of paint. God, I was born for this job. That's exactly how you fix a nail. You file it, you put a base coat and 2 coats of polish. There is nothing that prepared me more for the Navy than beauty school. Nothing. Ships are just giant nails with engines. So beauty school prepared me to fight every sailor's greatest enemy: rust. That's right, those giant ships out there are made of metal and they rust. Thank you, beauty school. So when I got out of the Navy, I was diagnosed in a VA hospital, and they told me I had scleroderma. I was 23. The only thing that a 23-year-old woman should be diagnosed with is chlamydia. And her biggest concern should be whether or not she should drink with those meds. Really. I was young. I didn't think I would get to see my 30s, but I just turned 50 this year. Yeah, I just turned 50. And I thought I'd be more tired, but I gotta say I feel pretty energetic, like I'm 19 again, you know, like I'm back to ready to go explore and see the world, only this time the Navy won't take me. I'll have to try to get a job at Carnival Cruises. I gotta say that the worst thing about Scleroderma is the name. Scleroderma is a terrible name. It doesn't sound scary. Scleroderma is scary. It kills people. And it's a marketing nightmare. Like, it's hard to spell, it's hard to pronounce. Nothing rhymes with scleroderma. Scleroderma is the orange of chronic illnesses. It just doesn't sound scary. It kills people. Well, not me, because I'm a Scorpio. Did I mention that? I'd like to thank my friends and family for all the love and support all these years, but I can't, because I'm a Scorpio. I survived because I'm a Scorpio. We're stubborn. I know we're known for being calculated and hot-headed, but the stubbornness in us is like, we get the job done. You know it's gonna get done. We never give up. And if you get in our way, we will destroy you. But we do, we get the job done. I think maybe I might be too stubborn to die. You know, because that's really the factor in scleroderma that's, you know, kind of feasible. Because when you first get it, you're like, I don't know what's gonna happen. You know, will it kill me? I don't know. I could get hit by a bus. I could have a heart attack. I could choke on a chicken wing. Scleroderma may not kill me, but now I'm afraid of chicken wings, heart attacks, and buses along with scleroderma. So might as well have survived because I'm a Scorpio. Maybe I'm a little too proud of that. I don't know. Having scleroderma is a lot like being married. At first, it's touch and go. You don't know what to expect. Then things get dramatic. You get to see the real scleroderma, and you find out just how strong you are. And you know, one of two things are going to happen. You're either going to kill each other, or you're going to compromise. And that's marriage, a lifetime of hostage negotiation. At least that's what I remember. You know, I've been dead once, and it's not due to scleroderma. I fell from the top of a flight of stairs and just hit the cement and landed, and my head popped open like a grape. Okay, maybe not that much, that's a little bit. But my husband, we'd only been married 2 weeks, and my husband ran downstairs in his underwear, and he gave me CPR and brought me back to life. If he hadn't acted fast, I would have had brain damage. Now, if we've been married 15 years, sure, my husband would have come to my rescue. He wouldn't let me die, but he might have put on some pants, shirt, maybe, you know, make sure that the life insurance is paid up, that sort of thing. All I'm saying, he wouldn't let me die, but there may have been a little more brain damage. That's all I'm saying. At least, maybe that's what I would have done, and that's probably why we're divorced. Well, it's either that or the Axe body spray. He started wearing Axe body spray, and it was like Karen repellent. And, but you know, I think that Axe body spray, the active ingredient, is what killed the dinosaurs. But I gotta say, Axe body spray is pretty ethical, because what I did when I got a divorce is I brought in 3 empty cans of Axe body spray, and I got a free membership to Match.com. I got free Juvederm and a discount on a mover. That's awesome. What more could a girl ask for? Or a woman, in my case. Let's get back to scleroderma. So when you're diagnosed, you have to change your lifestyle. And I was a 23-year-old college student who smoked when I was diagnosed. And so I quit. But I gotta tell you, I miss smoking. I miss smoking. look, it's not pleasant. You got to earn it, you know, not like kids today with vaping, you know, like I've never vaped, but you know, vaping, the first experience, it's like, it's delicious. I mean, those of us who smoked, we had to dig in our parents' ashtrays in the middle of the night and light up cigarette butts and smoke those. And we had to learn to tolerate them. We had to work for that nicotine. It's great. It's kind of like a badge of honor, you know? But like I said, I quit. And I smell better. I do smell better. But when I smoked, my car used to smell like hope and optimism, and I had more friends. And now my car smells like, I don't know, abstinence, regret, and red vines. Thank you very much. Enjoy the rest of the presentation.
So thank you so much, Karen. And I know some people had a little bit of difficulty with audio, and we'll just reassure you, we'll send you this link because it was really a fabulous and really funny presentation. I personally like the orange of diseases. I think I might use that in the future when describing scleroderma. Our next presentations are on sexual health, and we are very privileged to be joined by Dr. Kelli Gross and Dr. Erica Johnstone, two of our local experts, and will share with us a candid discussion about the impacts of scleroderma on sexual health. Our first presentation will be by Kelli Gross. Dr. Gross is a fellowship-trained urologist specializing in male infertility and men's health. She earned her medical degree from University of Texas and completed her residency at the Mayo Clinic in Arizona. She's someone we frequently refer patients to because she does such an excellent job and has a lovely bedside manner. So with that, I turn over the presentation to Dr. Gross.
Thank you so much for that. Let me get my screen shared here quickly. Okay, so talking about sexual function in men specifically, Dr. Johnstone's going to talk about sexual function in women. So when we're talking about sexual function in men, what can go wrong? There's a lot of things is kind of the long and short of it. So one of the things that we talk about the most is erectile dysfunction, because it has really big implications in the rest of sexual function. And it is one of the things that's easier to treat compared to some of the other things. But with all of these things on the list, there certainly are things that we can do. So other things that can be issues is ejaculatory dysfunction, and that can be ejaculated too quickly, ejaculated too slowly, even more things than that, different sensations with ejaculation, it going the wrong way, etc. All of these, none of them are dangerous, but can have a big function on sexual satisfaction and quality of life. One big thing too, associated with scleroderma, is changes in body image. So as your body image changes, then that certainly can affect how confident you feel about sexual activity, and, genital changes as well can have a big effect on that. Penile curvature is one of those things that falls into that category that may be a similar thing or can be totally separate. Sometimes people have enough penile curvature that it can cause difficulties with actually having intercourse. Changes in testosterone can happen that can change how people feel. Libido comes alongside with lowered testosterone, but that can happen aside from testosterone. It's a very multifactorial thing that can be from so many different things. Some people complain of genital pain and numbness. It's something I very commonly see people for. And infertility as well can be an issue. And this is just a start of a list, but this is what some of the most common things that I see people for. So what we know is sexual dysfunction is common. So overall, about 52% of men ages 40 to 70 have some degree of erectile dysfunction. It's more common with increasing age and also more common with other medical issues. Things like diabetes, for example, will increase this risk. Now, it's also likely more common in men who have scleroderma. So depending on the study we look at, it's 55 to 87%. Then probably if we look at men in the age range who are at risk for erectile dysfunction anyway, it's probably at least 80% or though. It may correlate with the severity of other scleroderma symptoms. And there's different reasons as to why this could happen. It could be related to the scarring of the penis. It could be related to vascular changes, for example. Now, men have scleroderma less commonly than women do, so it's not incredibly well studied. So all those other things on the list that I mentioned on the previous page, really not a bunch of studies about them. Erectile dysfunction is the most studied thing that we have in scleroderma, but we still need to kind of figure out some of the other things. But overall, these are all things that commonly happen in men of, every age, any sort of medical background. We see all of those things from time to time. So how do erections work? So this picture on the right side is if you took the penis and kind of were looking at it in a cross section, essentially. So this here is the top of the penis where the blood vessels are. This is the urethra, the bottom, and these two are the erectile bodies that the blood fills through. So whenever a man is sexually stimulated, then that causes a nitric oxide pathway to become activated. And this pathway causes smooth muscles to relax. And then also you get some dilation of the arteries of the penis, which lets the blood in. So you get engorgement of the penis. And all of this blood filling this area compresses the small veins against the erectile bodies, that hard connective tissue there, which is called the tunica albuginea, and that keeps the blood from leaving through the veins. So there's a lot of things involved. So a lot of places that this can go wrong. So what would we typically do if you were visiting somebody specifically for men's sexual function? Kind of course, depends on the issue. So we'll get a thorough history. So when does this happen? How long has it been happening for? What exactly are you experiencing? That's the most important part of everything, because in this, the majority of the diagnosis is just based on what you tell me. Physical exam can also be helpful, particularly if there's issues with penile deformity for whatever reason. That can be something that an exam can be very helpful for. Sometimes we'll also do labs, such as hormones. We check the testosterone very frequently. If we need to, sometimes we'll screen for diabetes, for example, or other health issues, and urine tests from time to time, depending again on the complaint. We also have other tests that we do as far as imaging tests. One of the more common ones that we do for sexual health complaints is a penile ultrasound. That gives us more information about the blood flows to and from the penis. It gives us a little bit of information of what exactly is the cause of the issues. So what can we do? Of course, it depends on the problem. We'll focus a little bit on treatment of erectile dysfunction. So there are a ton of treatments of erectile dysfunction. If you go to a urologist that specializes in men's health, we often say that we can pretty much give anyone an erection as long as they're open to the treatment options. So medications are where a lot of people start. They're pretty affordable nowadays. The side effects typically aren't too bad. And those are medications like Viagra, Cialis, et cetera, but they're generic now. So those can work. Now, men with scleroderma may not respond as well to those medications as men without scleroderma, but typically, since again, it's cheap, it's pretty easy, it's typically worth a try. There's a lot of other different options. So there's injections directly into the penis, which I know sound terrible, but are not as bad as they sound for most people. There's devices like a vacuum device, there's urethral suppositories. We do a surgery that's a penile prosthesis, which is that one thing I was saying that works for pretty much everybody and who can have surgery. So those are some of the basic options. We also do things like shockwave therapy. Now that is still not FDA approved. It's still technically experimental, but I actually did see a study specifically using it in men with scleroderma. So I thought that was pretty interesting. Now, in 10 years, it may not be experimental, but now we are doing it. It's just insurance is typically not going to cover it. So it's not exactly the cheapest thing. And we also don't know how long those effects last. So there's pros and cons to that choice, but it's an option for people who are interested. Again, there's a lot of different options. So any of those, if they sound good to you, we can typically give them a try. There's not a lot of contraindications or reasons that we can't use most of those therapies in people. There are some, but again, for most people, we can figure out a treatment that will work for you. One thing we also very frequently do is checking hormone levels. So we talked about that. So if the testosterone is low, which is one of the main things that we check for, replacing the testosterone can help with energy levels. It can help with erectile function. It can help with sex drive or libido. I didn't see any studies of that being different in men with scleroderma, but I wouldn't be surprised if it was. We've shown that low testosterone is related to a bunch of different medical conditions. You name it, it's probably been related to low testosterone. We also do referrals to sex therapists. So coping with sexual health and sexual function is difficult. So there are specialists who specifically can help with getting around these things. So techniques for certain issues. And also, why am I so anxious about sexual function? Why am I, not happy with why do we not enjoy having sex? Sex therapists are really good at addressing those things. We also have physical therapists who can help with, for example, pain syndromes, depending on what the complaint is. If there's bothersome penile curvature, then we can also straighten that as well. We have different options. Typically, we talk about doing it surgically, but again, there are some less invasive options depending on the situation. And again, with any other sort of complaints, so with ejaculatory issues, for example, we have medications that can help with that. We have techniques that we can help teach people, which can be helpful for those kinds of things. As far as ejaculatory function, pain syndromes, for example, we have a lot of different treatments for testicular pain. So again, it kind of depends on what the complaint is, but if you've had it, we've probably heard it, and we may not have a solution every single time, but we can usually take a stepwise approach to getting things better. So that is all I have. I think Dr. Johnstone will be next.
Thank you so much, Dr. Rose. That was fantastic. And I just want to remind the audience, if you switch your messaging from everyone to just the panelists, you can ask questions, and then Rachel and I can ask those if you don't feel comfortable sharing your name. We really want this to be informational and everybody to get their questions answered. So it's my pleasure now to introduce Dr. Erica Johnstone, a gynecologist and reproductive endocrinologist in the Division of Reproductive Endocrinology and Infertility at the University of Utah. Dr. Johnstone received her bachelor's degree from Yale University and earned her medical degree and completed her residency at Duke University. She's a phenomenal physician and, again, fabulous bedside manner. We're so lucky to have her at the University of Utah. So Dr. Johnstone, I turn it over to you.
Thanks. I am very glad to be here and very excited to be talking to this group today. I think some folks on here know my mother had scleroderma, so it's something that I care about and that's really important to me. And today we're going to talk about sex, which is always fun. So for women, so about 1/3 to 2/3 of women with scleroderma have some sort of sexual concern. Now, the good and the bad news about this is that sexual problems are common in women everywhere. In women in every country, in women with serious health problems and in women without. So about 20 to 40% of women in the general population also have sexual concerns. And this means that we have options and that we have things that we can do. Interestingly, so the fact that there are sexual problems in women with scleroderma is actually really well studied. There are a lot of studies on, the fact that women with scleroderma have sexual problems, going into exactly what those problems are, what's more common, what's less common. The disappointing thing is there's a lot less research into what is the best way to treat sexual problems in women with scleroderma. And so a lot of our options are options that have been studied in other patient groups, but I think there's also good reason to think they can really be helpful. Interestingly, it has been studied, and most women with scleroderma don't talk to their doctors about their sexual concerns, even though many want to. And so I think the first thing I want to do is encourage people to talk about sexual problems with their doctors, talk about what they're experiencing, ask about what the options are, because I think that can be really helpful. So you've probably heard this before. What is the most important sex organ? It's the brain. And so we think about sex, particularly for women, sexual desire is the very beginning of the process, and it's really important. And when we think about sexual desire, it's this really complex feedback loop, but there's desire that just kind of comes from you, that leads to willingness, that leads people to seek out sexual stimulation. There's all sorts of processing that goes into the brain, that goes into arousal. There's also that desire leads to physical arousal, that leads to responsive desire. It also leads to the reward, which is physical and emotional satisfaction, which brings everyone back to motivation for sex. So what that means is that enjoyable sex leads to more enjoyable sex. And it primes our brains to be interested in sex and to want to have sex. When we think about sort of the more physiologic parts of sex, desire, which comes from the brain, leads to excitement, but there's also physical parts of this that come from our nervous system, and that leads to the experience of arousal. So the clitoris enlarges, the small blood vessels around the vagina start to dilate. The inner 2/3 of the vagina actually expands. This leads to the plateau period of sexual enjoyment, where we see the vagina actually increases in length. And then ultimately we get to orgasm, which involves contraction of pelvic floor muscles. We see the whole body's involved in orgasm, heart rate, blood pressure, breathing rate, all of these things go up. And simultaneously, the outer third of the vagina becomes congested and then contracts in a rhythmic fashion. And ultimately, after this, there's resolution and the experience of satisfaction. So then when we think about women with scleroderma and sexual desire, so what are the factors that play into sexual desire? Well, a lot of them are the same factors that play into sexual desire for everyone. But they're important things to think about when somebody's not having the sex life that they want. Relationship satisfaction, mood, people who, when you're feeling anxious or depressed, you're less likely to be thinking about sex. Overall energy level, if you're exhausted, you're not less likely to be interested in sex. Body image and mobility concerns for women with scleroderma play into their desire for sex and their interest for sex. And then if you've experienced pain with sexual activity, that's also going to diminish desire. Then when we think about the actual sexual activity itself, some of the challenges that are faced just as skin changes and becomes tighter in women with scleroderma, the vagina can become tighter and drier. There's also issues with blood flow. So blood flow to the clitoris can be decreased and this tends to be associated in people who are experiencing hand ulcers, capillary problems that also can affect blood flow to the sex organs. And finally, medications and treatments may also have direct impacts on arousal, lubrication, and orgasm. So then the question is, what can people do about it? So we start with low sexual desire. So low sexual desire is actually the most common sexual problem in women altogether. So whereas Dr. Gross talked about, for men, often the sexual concerns are more physiologic, are more related to erection. For women, it's often not having the desire to begin with. So the first thing to think about are relationship factors. Are there, is there conflict in the relationship? Has scleroderma led to a change in the relationship? And that may be affecting sexual desire and sexual interest. So this means that relationship counseling and steps taken to focus on a relationship can improve sexual desire, even if it's not specifically sex therapy, but we will talk about sex therapy. Mood. So it's important to treat depression and anxiety, and depression and anxiety are really common in women with scleroderma, and sometimes tend to be a really tough thing that can happen shortly after diagnosis, as you're kind of coming to terms with the idea of the new diagnosis and how it changes your life. And there are a lot of great treatments for anxiety and depression out there. But one of the most common ones, so SSRIs, and so this is medications like fluoxetine or Prozac, sertraline or Zoloft, citalopram or Celexa. So these really common antidepressant and anti-anxiety medications often have negative effects on sexual desire and sexual function. And we're just starting to learn how important it can be to consider alternatives. So some of the medications that can treat depression and anxiety, but don't harm sexual desire, and maybe even make it better, would be things like buspirone or bupropion. And so this is something that I would encourage people to talk to their doctor about this. If you're using a medication for mood symptoms, talk about the sexual side effects you're seeing. Talk about, I think sometimes it needs to be said that, hey, it's important to me to still have sexual desire. And so if that's not working, one, you may be able to change medications, or one of these medications may be something you can add that may really help. Other things, energy level. So one of the things that can really help is planning sex. So for women, a mentor of mine used to say, for women to really want sex and to really enjoy sex, they have to have kind of an empty brain. There can't be a million competing things in your brain. So plan a time for sex and plan sex for a time that your energy level is at its best. And that's different for different people. So for some people, that might be in the morning. And so it may be good to talk with your partner and say, we're going to plan to have sex in the morning. We're going to make time for it. We're going to plan it for a weekend morning. Maybe we're going to take some time off of work. For other people, it may be in the evening, but maybe it's not at 11 p.m. right before bed. Maybe it's a relaxing dinner, having some time, but again, planning for sex at a time that you're more likely to have the energy to really enjoy it. When it comes to body image, so some of the factors that play into this are, body changes in the mouth, changes in the vagina, changes in the hands. Physical therapy can do a lot in these areas to kind of maintain function, and that can also be important and really help with sexual desire. There's an FDA-approved drug called flibanserin, and it has actually been studied and seems to improve sexual desire. So this is also something that you could talk with your doctor about is this a good option for you to help with sexual desire? But again, first and foremost, I would say talk about these concerns. This is not something anyone should feel embarrassed to talk about. This is, enjoyable sex is a really important part of human life. How about difficulty with enjoyment of sexual activity? And this kind of includes the whole thing from arousal, lubrication, orgasm, all of these things, where you may be experiencing the desire, but then when you actually get to the sexual activity, you're not enjoying it as much. So again, making time for sex is important. It may take longer to reach orgasm. It may take longer to really enjoy it. So finding times that you can do that is really important. One of the things to think about, start with a warm bath or shower. That can kind of really open up dilated blood vessels, and then keep the room warm. I think it's really important to talk to your partner about, gosh, being naked in an ice cold room, I'm going to, my Raynaud's is going to flare. This is not going to be a good experience for me. Spend some time for erotic visualization and sexual fantasy. Let yourself, if you're planning sex, think about sex during the day. Think about things that are exciting to you. When it comes to issues with vaginal tightness and pain with intercourse, pelvic floor physical therapy is a really great option. And so they can work with dilators to really stretch out the vagina, help with flexibility. And there are times when one of the challenges that women can face when it comes to sexual function is the vagina becomes a little tighter. But then after you've experienced pain with intercourse, those muscles, there's kind of a reactive response in those muscles that they tend to tighten down with any kind of contact, even thinking about sex or any sort of foreplay. And so with pelvic floor physical therapy, that can help you to get rid of that part of it, the muscular tightness, and then using dilators to help with the actual tightness of the skin. There's also physical therapy options that can help with mouth flexibility and hand flexibility to keep, to allow your whole body to be part of the sexual experience. Vaginal dryness is a really common concern for women with scleroderma. And it's something to think about, so during sex, lubricants are a really good option. But keeping the vagina moisturized all the time is important as well. So some women may be good candidates for vaginal estrogen. This is particularly women who may have gone through menopause. But there are also vaginal moisturizers that are designed for everyday use. And this keeps that delicate tissue inside the vagina really healthy so that when you want to have sex, it's much more likely to be pleasurable. And then other things to think about is because there is decreased blood flow to the clitoris, vibratory clitoral stimulation can be really important for achieving full arousal and orgasm. And it just may take more time than someone expects, more time maybe than it did before a diagnosis, but it's still definitely an option and something that can work. Then the question is, what can I try at home? I think, I know I have learned that people often wait a while before they come to the doctor's office to seek help. And not everybody feels comfortable or ready to talk with a sex therapist early in the process. But the good news is there are some things that you can try at home. So there are actually apps dedicated to female sexual desire and response. I think everybody knows there's plenty of porn on the internet, but a lot of these sites and images aren't designed for women. And so there are a couple of websites and apps out there that really are designed to give women options to improve their sexual desire. Lubricants are important. So if you're using condoms, you want to use a water-based lubricant. But if you're not using condoms, then oil-based are good options. And actually, interestingly, some of the oils you may find in your kitchen are really great and not expensive options as sexual lubricants. So coconut or mineral oil. Some of these things you might want to try on your skin before you use them sexually, just to be sure you don't have any kind of reaction, because you wouldn't want to have any sort of irritation reaction vaginally. And then vibratory stimulators. So there is actually an FDA-approved vibratory stimulator for women. It's really expensive, and I don't know how often it's covered by insurance, but there are also all sorts of other devices out there that may be much more accessible in terms of vibratory stimulators, and these are, generally relatively inexpensive and safe. And then be creative with positions and specific sexual activities. If you find you're limited in mobility in certain positions and certain activities, try other positions, try other activities. Really don't be afraid to talk with your partner about what you need to enjoy the experience, because there are some things you can try. And then finally, I do really encourage people don't be afraid to seek out a sex therapist. They can help with the whole process, from desire to all of the other issues along the way. So how do you find a good sex therapist? So there's this group called the American Association of Sex Educators, Counselors, and Therapists, and they actually offer training and certification. And so if you go to their website, you can look for someone who's in your community who really is trained in sex therapy, which I think can be important. There are lots of other therapists and counselors who involve talking about sex in their practice, but these are people who really have special training and I think really can offer a great benefit in terms of sex therapy. And then just talking a little bit about contraception for women with scleroderma who want to have sex and don't want to be pregnant. So one, there are lots of good options out there. What's going to be the best option for you is going to be very individualized, but most women are good candidates. Most women with scleroderma are going to be good candidates for things like the IUD, the intrauterine devices, either with or without progestin, or things that have hormones but have progestin only. So that can be an implant that's placed in the arm for 3 years, Depo-Provera shots, progestin-only pills. The forms of contraception that it's really important to have a really personalized discussion about are anything that contains estrogen. And that means most birth control pills, the NuvaRing, which is a vaginal ring that provides contraception, and then the contraceptive patch. So these are not safe if someone has significant heart disease, cardiovascular disease, any kind of vascular disease, or antiphospholipid antibodies. So for these options, again, it's really important to have a very personalized discussion. But it's important to know that there are contraceptive options, and it's always okay to seek out. I think as you talk to your doctor, you'll also talk with a gynecologist about the options and the particular risks and benefits for you, because we want people to be able to have sex without having a pregnancy when it's not the right time to be pregnant. Well, thank you. And I'll turn it back over.
Thank you. Excellent presentation. And again, we really just appreciate you taking the time on your Saturday and staying around for questions. So thank you so much. Our next group of speakers will be addressing scleroderma medications. And we have two fabulous speakers. The first will be Dr. Jessica Farrell. She received her PharmD from the Albany College of Pharmacy and Health Sciences. Dr. Farrell's teaching and research activities focus on drug therapy and autoimmune diseases, including rheumatoid arthritis, scleroderma, and systemic lupus erythematosus. Dr. Farrell is also a member of the research team at the Stephan Scleroderma Center and is a member of the Scleroderma Foundation's Medical Scientific Advisory Board. Dr. Farrell was the recipient of the Scleroderma Foundation's 2019 Doctor of the Year Award, and she has done remarkable work getting CellCept or mycophenolate available for our patients. She has truly saved lives in the scleroderma community, and I'm just very grateful that she's here with us today.
All right, so Dr. Harper and I had talked briefly. There's a lot of information to cover in a very short period of time. So we're both going to go quickly, and we're happy to answer questions at the end. I know that many of you have listened to my presentations at the national conference. So I wanted just to focus on a couple medications today. Specifically some reminders about steroids. We'll talk a little bit about mycophenolate, and we'll talk a little bit about some newer options for ILD, since this is kind of an area of increased research and options for patients with scleroderma. So I always talk about this when I present on medications of scleroderma, because I think it's really, really important for everyone to recognize that, there are lots of different options for patients with scleroderma. And if you put 10 patients with scleroderma in a room together, their medication regimens might look very different. So it is important that we are treating the individual and organ specific for that patient. So there's not a single drug therapy that been found to treat all aspects of scleroderma. So oftentimes patients are on multiple medications for their scleroderma, and that treatment plan is developed by their provider team based on the patient's manifestation. So targeting either inflammation, autoimmunity, vascular disease, or tissue fibrosis. It is important that we recognize that screening and early treatment to prevent and improve disease outcomes and slow disease progress if possible. I always mention this too. So Dr. Fack mentioned about mycophenolate being off-label on the CMS compendia, which allows it to be covered under insurance. And there really are very few medications that are FDA-approved indications in scleroderma. So it can lead to problems with getting medications approved, and it can also lead to maybe confusion or not so, or other providers not really being aware of the use of the medication for patients with scleroderma. So we'll talk a little bit about corticosteroids. Just a reminder, so corticosteroids are really great drugs for patients with inflammation, patients with inflammatory disease. We use them in lots and lots of different disease states that have an inflammatory component. And some patients with scleroderma may need steroids either for short periods of time or a low dose chronically. So I just wanted to talk about some of the safety concerns and some of the things that just reminders, and for you to talk to your provider too, just to be an advocate for yourself in terms of safety and monitoring for long-term use. So corticosteroids are a synthetic cortisol. So cortisol is something that all of our bodies produce. It is in equivalent to prednisone equivalents. It's about 5 milligrams of prednisone that every individual approximately makes a day. So, if we go above that amount, we start to see some potential side effects. So we, at times we might need to go above that to get some inflammation down, but we try to keep it, those high doses, tapering down to lower doses as quickly as possible to prevent some of these long-term side effects. So some patients might notice that in the early stages of taking corticosteroids or prednisone that they'll notice that they have trouble sleeping. So we always recommend to take it in the morning if you're on the once a day dosing, unless you're on a brand name called Rayos, which has a little bit of a different delivery system where that one's taken at nighttime. Patients might notice that it affects their appetite and it cause some mood swings. So you might have to let your family know. I have to be on a short course of steroids, so please excuse my extra craziness. Is that sometimes my patients tell me that their family members don't like them to be on prednisone. We do have to be careful in patients that have high blood sugar or diabetes, so we'll have to, try to use them sparingly in that patient population. And then long term, I think a couple of the things for patients with scleroderma, you're already patients with scleroderma might be on other immunosuppressive therapies that can put them at an increased risk of infection. So any type of infection, whether it be, a respiratory infection, an upper respiratory tract infection, a skin infection. So we do have to be careful. The longer we keep you on, corticosteroids, we just need to be mindful of that. And then long-term osteoporosis. So patients with autoimmune diseases in general are at higher risk for osteoporosis. So low bone density. Having low bone density can increase your risk for fracturing. So we do need to address that, and you might be a candidate for early DEXA scans where we look at your bone density. And then GI irritation. So we have to be really careful because the GI tract is involved in scleroderma. So we do need to make sure that we're, keeping track and limiting the combination of prednisone plus NSAIDs like ibuprofen and naproxen. So this kind of just goes over a couple of those other things that I already mentioned. If you have to be on chronic prednisone, we do try to get you to the lowest possible dose. And we never want to stop abruptly unless you're only on a short course. So if you've been on it for many weeks, we want to make sure that you're having a conversation with your doctor about how you're going to stop the medication. And that's very important. And then in patients with scleroderma who are RNA polymerase III antibody positive, we do need to be careful about how much prednisone you're exposed to, because that can increase the potential to increase the risk for scleroderma renal crisis. So let's talk about mycophenolate, maybe one of my favorite drugs. I have a very close relationship with mycophenolate. Most patients with scleroderma, this drug has been really game changer, I guess, one of our earlier game changers in scleroderma. It works really well for many aspects of the disease. And although it does have some safety concerns, we know them and we can monitor them and we can adjust the medication and the dose to prevent those or lower those risks. One of the biggest things that I see with patients is that because patients with scleroderma often have Sjogren's or dry mouth associated with their condition and have esophageal issues, is that swallowing the tablets or the capsules can be a challenge. So if you're on the 500 milligram tablets and you're having trouble swallowing them, I always recommend trouble swallowing. You can use some lubricants like Pill Glide or Biotine to help with you swallowing your medications. And then the 250 milligram capsule is a little bit smaller, so that might be an option. You might have to take more of them, but that's something that you could trial if you're having trouble taking it. We do want to watch out for its timing and taking it. So your medication bottle might say that you need to take it with food. So one of the bigger issues that I find with scleroderma patients is that taking it in combination with their proton pump inhibitor like omeprazole or Protonix or those medications. So it's really important that you try to take your first dose of mycophenolate before, at least an hour and a half before your proton pump inhibitor. And that really helps the absorption of the cell septs specifically, because it needs an acidic environment for full absorption. So if that's something that you're not doing yet, have a conversation with your rheumatologist or maybe your pharmacist to talk about timing of medication and how to space out your medications. If you get nausea with it, you can take it with a little bit of like crackers or a small snack if it doesn't correlate with the time of day where you're having a meal. Your doctors are going to look at your blood counts and watch those. So looking for decreased blood cell counts that can cause anemia, changes in your platelets, which can cause bruising or bleeding. And for our women of childbearing age, it's very, very, very important that you are on an adequate form of contraception and that you do not get pregnant while you're on this medication. And if you're planning pregnancy, that we obviously have a conversation with your provider team about how to come off the CellCept and safely conceive. I think I talked a little bit about some of these. I jumped ahead a little bit and talked a little bit about these beforehand. I would say that the nausea, you can build tolerance to. A diarrhea can be a rate limiting step and also a challenge in our scleroderma population. So again, something that we might have to work around. Most patients do build tolerance to it. All right, so let's quickly talk about therapies for lung disease so that I leave Dr. Harper enough time. The next couple slides are a little technical, but basically, rituximab is a medication that is being actively studied in scleroderma ILD. There have been some small studies and some open label, meaning that it is, everyone knows what medication they're getting, the doctors who are treating so the study design isn't as strong, but it's still good information to have. So basically the Rituxan group compared to the cyclophosphamide group, there showed improvement, and cyclophosphamide or Cytoxan is one of our medications that we might have to use in more severe disease, and it has a lot of side effects. So we're always trying to find alternatives. And Rituxan group actually had an improved FVC, so that one of those markers for lung function. And there are a couple of ongoing studies that are randomized studies looking at Rituxan. We'll talk about some of the safety concerns with Rituxan in a second. And then this slide really just shows that this is not new news, but I'm sure Dr. Khanna has talked to you before, or you listened to his presentations, but the focused investigator group that looked at tocilizumab or Actemra in patients with scleroderma, looking at skin scores. That's what this value here is, the modified Rodnan skin score, and then the lung function, so the FVC percent. And you can see this slide here shows that in the placebo group, you saw this decline in lung function, whereas in the tocilizumab group, you see that there was an improvement and stability there. So those are, were really positive results. What else do I want to mention? So this, again, a little technical, but it now has FDA approval for scleroderma-associated lung disease. So a few things. So these medications are really very, very important medications in rheumatic disease in general. The good news for you guys in terms of scleroderma patients, these medications have been used in other rheumatic diseases for many, many years. And that, in my mind, helps me be more confident that we know what to expect from these medications. So we know the safety profile, we know some of the things that we're concerned with. So, particularly with Rituxan, it is a big gun in terms of suppressing the immune system. So, risk of infection. We know that we need to vaccinate before we treat you with Rituxan if possible, that it can affect the vaccine response. So that's something really important in the current day. It does have a risk of infusion reactions, and it is a long infusion, but you're being monitored very, very closely in an infusion room with nurses. So those are things. And it's depending on the treatment plan, it's given either as 1 dose or 2 dose over the course of 2 weeks, and then repeated possibly in 6 months. So depending on why your doctor is using it. We do need to be mindful of a very, very, very rare side effect called progressive multifocal leukoencephalopathy, PML, incredibly, incredibly rare in the rheumatic disease population. There are very few reported cases, but it is something that we need to think about where it can cause some neurologic effects. Tocilizumab, unfortunately, COVID is stealing all of our medications right now, so it is a little bit challenging to get right now, but it is, so the IV form and then the subcutaneous form, so that is an issue right now, but tocilizumab is the medication I mentioned, is one of the drugs approved for scleroderma-associated ILD. You do have to watch your blood counts, your liver enzymes. We do have to be careful in patients that have had history of diverticulitis or perforations in their bowels. But this is a really good medication because it works pretty quickly. And again, like I said, we know what we're looking for and we know how to use this medication because it's been used in rheumatoid arthritis for a long time. Lastly, I'll talk about nintedanib or OFEV, which was one of the first medications approved a couple years ago for scleroderma-associated ILD. I recently did a presentation for another organization, and I did it. It was in combination with a pulmonologist, a pulmonary nurse practitioner at National Jewish Health, which is one of the leading health lung centers in the country. And they've been using this medication in their scleroderma population and seeing some good results. It's working on the fibrosis, so it's not working on the inflammation piece. Patients are often using this in combination with mycophenolate. This is kind of an add-on therapy. I imagine my thought is that, it might be something we can add on to some of our other medications too. But the rate limiting step with this medication is diarrhea. So some patients do build tolerance, but that's kind of the rate limiting step. But the studies suggest this medication really does help slow and decline in lung function. And, anecdotally, I've been hearing good things from the pulmonary team. All right, I'm going to turn it over to Dr. Harper so that she's able to talk to you guys about CBD and low-dose naltrexone, and we'll answer questions at the end. So sorry, that was like speed dating with medication. So.
Well, thank you. Excellent presentation, lots of important information. Our next speaker is Dr. JoAnna Harper, who is a multiple state licensed consultant pharmacist specializing in pain management with a personal emphasis on scleroderma and lupus. Dr. Harper received her doctorate of pharmacy degree from Oregon State University and a bachelor's degree from the University of Arizona in molecular and cellular biology. She brings a unique firsthand approach to the effects of medications in scleroderma patients with her early childhood diagnosis of Raynaud's scleroderma and lupus, along with a host of other conditions related to scleroderma. Dr. Harper has volunteered extensively within the Scleroderma Foundation for a variety of roles for the past 27 years. She's a fabulous speaker and a wonderful person, always willing to talk to our patients. So I thank you, Dr. Harper, for joining us today.
There we go. Thank you for having me. The slides should be viewable. So I'm going to talk about low-dose naltrexone and cannabis. I'm going to try and do sweet and simple. As we all know, it's a little difficult to do with medications, but these are tips specifically for scleroderma patients. You will find little nuggets throughout that actually are little pictures of my child at the various conferences, as well as through the years with scleroderma. She does not have it, but she is a big supporter. So the objectives really are just really quick, understanding how low-dose naltrexone works, how the limitations associated with it, dosing options, as well as side effects and drug interactions, and similar for cannabis, except going into the differences between hemp and marijuana, CB1 versus CB2 activity, and why CBD is preferred for scleroderma patients over the full spectrum products. So just to clarify, low-dose naltrexone is not related to CBD or THC in any way. They're just two out-of-the-box medications that are available for scleroderma or other autoimmune inflammatory type conditions. So each compound has been around for a very, very long time. Research is not exactly up to par with where we would like to be, but we're working on that. So each one has a totally different mechanism, but they can be used together. So low-dose naltrexone, what we know about it as far as research, it's an opioid antagonist. So it blocks the opioid receptor from receiving pain medication. So it's used for addiction at a 50 milligram dose. Now that's the levonaltrexone. So that's one enantiomer. The other enantiomer is the dextronaltrexone, and that's the one that we are looking for in a low dose form. That's the mechanism of action, and it affects microglial cells. And we know that microglial cells help modulate the immune system, but also modulates pain. And so we've found that adjusting these microglial cells allows us to have a neuroprotective property, as well as reduce inflammation and potentially even downregulate cancer genes and other things. And again, research isn't exactly where we want it to be, but we've been using it for many, many years in this capacity. So, and then there is also another mechanism of action for filament A, which is another type of protein for opioid receptor signaling. So just giving you an idea that there are a lot of ways that low-dose naltrexone works, and the dose depends on what mechanism is active at that time. So we are shooting for the dextronaltrexone and the microglial cell activity. So we find that it can be effective for itching, especially with scleroderma, fibromyalgia, Lyme disease, and inflammatory bowel disease. There's a whole laundry list of other things, but we're not going to go through with with that information today. But the question is how do you know it's going to work for you? And so if anti-inflammatories are effective for you, ibuprofen, naproxen, prednisone, meloxicam, if those are effective for you, oftentimes with my patients, I find that low-dose naltrexone can be incredibly helpful for them. So that's usually a positive attribute, and that's usually the first patients I put them on for this medication. So we avoid it if you're using long-acting opioids, so Oxycontin, morphine, extended release, methadone, buprenorphine, all of which they fight for the same receptor. And I'm going to tell you, there have been cases of withdrawal, even with very low dose naltrexone with those patients. And then also with transplant patients, because there is an interaction with the transplant drug or the anti-rejection drugs that you take. So that is, again, one of the things that we're avoiding at this time. There's always the question of who will prescribe, and that's a great question. And it is one of those topics that is controversial. There's not a lot of information, and it's not taught in medical schools, and it's not FDA approved. So all of that being said, this website at ldnresearchtrust.org has a list of prescribers that have registered with that site to say that, yes, they prescribe low-dose naltrexone. At the end of the talk, or middle of the talk, we'll talk about some different sites that you can go to print out information for your provider to let them know that there have been success stories, so on and so forth. And there is also a free health tracker app through the LDN Research Trust as well, which will help provide information to your provider back and forth. So, low-dose naltrexone, again, I tried to be sweet and simple. Dosing, I'm going to tell you for scleroderma patients with high inflammatory markers and a lot of chronic pain, I usually only start at 0.5 milligrams. Most providers will start at 1.5 or even 4.5, but I found that the side effects are too severe in those patients. If you don't tolerate medications well or supplements and you always have side effects, I would start at 0.1 to 0.2 milligrams. These have not been tested at the 50 milligram dose for any type of liver or renal impairment. So if you have severe liver or kidney involvement, you may want to talk to your provider about it. And it doesn't mean that it's not acceptable. It just means that you're going to have to be really cautious just because there's no studies. Stop at the lowest effective dose or go back to the last dose that was effective, because higher does not mean better, because again, it goes to a different receptor. And then the max dose usually I use for pain is 9.5 milligrams. And again, I've gone as high as 12.5, but usually the effective daily dose is 4.5 milligrams a day. So with titration, you always start low and go slow, usually daily dosing at night, unless you have anxiety. And if side effects, you stop for 3 to 4 days, 2 to 3 days, and then start at half the dose. And then increase every 7 days if you're stabilized. So if you're having side effects, make sure that you stay on it a little bit longer until those subside. So the side effects: increased pain initially, which I know sounds horrible. Believe me, this year has been rough for me with pain, so I completely understand. But other ones include anxiety, headache, abdominal pain, and vivid dreams. Vivid dreams are almost guaranteed. I'd say 90% of my patients have vivid dreams. But good news is that it's dose dependent. So the severity is depending on how high the dose is. And that is a good indicator that it can be successful for you. That means that I'm hitting the right receptors that I want to hit. There is higher GI upset with inflammatory diets. So if your diet is really bad with processed food, you can anticipate a higher GI upset with this medication. And avoid moderate to excessive alcohol use with this, because again, it is used for addiction and other things. So drug interactions, you must be stable on biologics for 3 months in order to start this medication. Prednisone and methylprednisolone, you need to be on a dose less than 20 milligrams a day, and then avoid with ketamine. And then the other caveat is, because it does block pain medications, you discontinue low-dose naltrexone 1 to 2 days prior to surgery, and then restart after post-op meds are no longer needed. So without a titration, you can start back at the original dose that you had. And that way, to make sure your pain medications will be effective. We don't want them not to be. Cost, generally it's $45 to $80 a month, depending on the dose and depending on the pharmacy. A lot of times I can get bulk discounts depending on how many patients they have with that medication. Insurance is starting to cover this, and I know some state plans cover it as well, so that's really hopeful. Their 90-day supply makes it much cheaper. And if your insurance has issues with this or they say it's denied, please have the pharmacy staff call your insurance, because it may need to be ran a specific way that the pharmacy knows how to do. And any compounding pharmacy can do that. So I prefer getting it locally because I know what products they're using. I know what fillers they're using. Usually the least amount of fillers, the better. There are other options if you do have side effects for different fillers. And I believe that's in another talk of mine if you just search low-dose naltrexone. And then there is less GI upset with sublingual. So the information available to bring to your provider is all available on ldnresearchtrust.org, and all of the websites are there for fibromyalgia, and then a few case studies out of New Jersey, Sjogren's, as well as pain. And these are all articles. They update these quite often, and there are many, many publications out there available to help sell this to your provider. So unfortunately, it may be an uphill battle on that one, but I will be here to help with any research that you may need. So cannabis, the one thing that everybody wants to know about, we're going to talk about hemp versus marijuana. So we're going to go through the classifications real quick because it was confusing for a long time for me as well. So cannabis is the genus name of the plant, similar to canis for dogs and wolves. So that's the genus. And then there's species, which is below that. And that's like differentiating between dogs versus wolves. So there's 120 different species of cannabis. You have one species, which is hemp. And hemp is often cannabis sativa, which has less than 0.3% THC, or supposed to. And then there's marijuana, usually medical or recreational use, and that's usually cannabis indica as their species, meaning that they have a much higher content of THC, and it can be as high as 30%. So that is significantly higher than the cannabis sativa. So there's 568 different molecules in cannabis. So we have a lot to learn still. We only know a little bit of this, and research is still in process. So just so that you know, progress is being made, but I'm telling you what we know right now. So CB1 versus CB2 receptors. Cannabis as a whole moderates dopamine, so the feel-good chemicals. It helps endothelial cell or skin cell function. It has involvement in a lot of the metabolic processes in your body. And we're still figuring out more and more where these receptors are located, and they are located all throughout the body. So CB1 receptors are specifically for smooth muscle vasodilation and to decrease inflammation, but they're also the psychotropic aspects, and they're also pro-fibrotic. So that's one thing that we want to avoid in scleroderma. And then CB2 receptors specifically modulate the immune system, so decrease inflammation, stimulates regulatory T cells, so on and so forth. And this also includes the microglia that we talked about earlier with low-dose naltrexone. So that's a little bit of overlap there. And then the CB2 receptor medications are used for autoimmune conditions primarily, rather than CB1 receptor agents. So THC binds to both CB1 and CB2. And it's important to note that there may be some fibrotic activity if you're using a THC product. And then CBD activates CB2, which is great. That's what we want. And it may actually modulate CB1 to use the benefits of CB1, so the decreased inflammation, in a way that's beneficial rather than pro-fibrotic. So there's a lot of polymorphisms, meaning your genetic makeup determines how your body is going to process this. Some process it well, some process it really horribly. And unfortunately, that's just the name of the game. So CBD Again, reduces inflammation, antioxidant properties, all good stuff. Antidepressant, very calming. And there's a lot of different clinical study or clinical cases where I've seen it decreases IBS symptoms. THC is often used for relaxation and decreasing muscle spasms and nerve pain. And it is used as an anti-anxiety, but again, it works on CB1 and CB2, which is not necessarily preferred, especially in higher doses. So, sweet and simple with CBD. CBD is preferred for scleroderma patients. And again, that's that CB2 receptor we're looking for. Sativa, which that's again part of a species, is activating. So that's sat up. And then indica, which from all of the places that I have visited on research, of course, is sedating. So in the couch or in the couch for indica. So that's the way to choose products, and then to choose the least amount of THC in each product, at least initially. So try CBD first. THC is much more difficult to tolerate for many, and many people require microdosing. So that's the minimal amount of dosing you can get in whether that's a herbal, a tincture, any type of oral compound or cream. I do not recommend smoking or inhaling in any way, and that includes vapes. We can say that there's no damage as far as there's no radiograph or x-rays that prove damage, but there is cellular damage guaranteed anytime you inhale something, just like inhaling smoke from a burning building. So there are THC concerns for children below 18 years of age. So using THC products is not recommended. CBD products are another thing that I do see being used more often, and it is a safer option. And ECN is a company that makes it available. And if you have questions, I can give you that information. You can just Google enhanced clinical nutrition, and they can you can order directly through them. And then demand to make sure you see purity testing. So any of the products that you buy, no matter where you get it, make sure that you're getting that documentation stating exactly what's in it, how much THC, how much CBD. It'll also should tell you the receptors that it's working on, as well as any type of microbes, fungus, pesticides, or metals. We all know that there's an environmental trigger with scleroderma. So let's not add to it. And then continue with the same product, because accuracy in dosing between products is never a guarantee. And you never know the quality and consistency of each batch of each product. So making sure you stay consistent, or if you do need to change, go to a lower dose to make sure that you're still staying safe. Make sure you review all of your state laws carefully. Just to give you an idea, oil and edibles are a felony charge in Minnesota, regardless of what's in it, CBD or THC. So that is something that you need to review very carefully and make sure you're following all of the guidelines of your law, because it is still federally illegal. Start low, go slow, and stay low. So again, increasing the dose may not be the best option. So get to a sweet spot and then try to stay there. And the goal is to wean off maybe opioids and benzodiazepines in order to decrease the amount of pill burden that you have, as well as the amount of substances in your body. And then make sure you communicate with all your providers, psychiatry, primary care, rheumatology, pulmonology. Make sure they all know what you're doing, because there are drug interactions, which we will talk about now in just a second. So side effects. I understand that CBD and THC are used for nausea. Okay. I'm going to tell you that a side effect often is nausea, especially at higher doses. So we actually see hyperemesis or cyclic vomiting with really high THC doses, but I've also seen it in CBD as well for nausea. And then with CBD also, you can have fatigue, irritability, and anxiety. And with THC, dry mouth. So that's, again, another reason I don't prefer THC products for scleroderma patients. Anxiety, Euphoria, which may not be necessarily a bad side effect, but you need to know that you're safe in a safe environment. And then vasodilation to the core, which means vasodilation or vasoconstriction to your fingers. So that means increased Raynaud's, and that is not necessarily the direction we want to go in. And then withdrawal symptoms are possible with THC. So drug interactions, again, we have limited data. The data that we do have says that it will potentiate or make worse any other CNS depressant medication. So benzodiazepines, alcohol, and opioids, the sedative effect can be much, much higher when combined with THC in particular. CBD, it can happen as well, but more so with THC. We have seen cases of mania with SSRIs, Prozac, fluoxetine, citalopram, all of those. And there have been some concerns with tricyclic antidepressants, so amitriptyline, nortriptyline, with tachycardia and delirium, increased risk of immunosuppression if you're on corticosteroids. So again, something that you want to talk to your rheumatologist about pros and cons and using this. And that was also another reason to stay low on this medication. It may decrease the effectiveness of antipsychotics, and it also works with competitive metabolism for CYP3A4, 2C9, and 2C19, depending on the THC versus CBD. Those medications need to break down and process other drugs too, as well as other processes in your body. So if we're having a lot of drugs competing for that same enzyme, the drugs won't be able to be broken down as fast. So the drug interactions here, it will increase the CBD and THC that you take. So a 5 milligram dose or 0.5 milligrams of CBD will feel like 1 or 2 milligrams with, say, fluoxetine, cimetidine, which we use for acid reflux, grapefruit juice, and then sulfamethoxazole, which is an antibiotic. And then increasing CBD is omeprazole. So you can start at a much lower dose with CBD if you're taking omeprazole, esomeprazole, cimetidine, fluconazole, or clopidogrel. And then the THC and CBD amount will be decreased if you're on bosentan or St. John's wort. So again, genetics affect this greatly. Some people are poor metabolizers, some people are fast metabolizers. So a genetic test will help determine that, but the best way to do it without a genetic test is to go slow. Start low, go slow. So that is the fastest recap I could do on low-dose naltrexone and CBD. And the questions are here with the panel at the end. Thanks for having me. I'll pass it right back off to you.
Thank you so much. That was excellent. And you all just really did a phenomenal talk on very difficult subjects. And we have lots of great questions. So I'm going to come back to the very beginning of the talks. And so we had a question for Dr. Johnstone. Can you address sexual dysfunction as well? I've noticed a change in the sensation of my pars intima as my disease has progressed. Is this related to thickening of the pelvis fascia? Is there a method to treat this?
So that's a great question and a tough one. Certainly, I think decrease in sensation can be related to thickening of tissues. It can be related to blood flow, which also affects the nerve. So there can be a lot of different factors there. You know, interestingly, sometimes so I wouldn't have advice on a very specific thing for that, but sometimes improving multiple factors, like sometimes the decrease in sensation can be improved by improving other factors, meaning other nearby tissues. Improving kind of the desire and overall arousal may improve sensation enough to improve overall experience.
Thank you very much. And the next question was regarding supplements, and I wanted to call everyone's attention to the chat if they don't have that up. Healthy.kaiserpermanente.org is a good natural database checker for medications and supplements. The question was regarding if your doctor doesn't know much about supplements, where can you go to get information? So I'd like to thank Dr. Harper for providing that link and direct our audience to that. The next question was regarding, and I think this is probably addressed to Dr. Farrell, is there's a participant who's experiencing a lot of coughing and phlegm in the morning. Water seems to be exacerbating it, and what would be the cause of this, or is there help with symptoms? So I think the question was regarding sort of medication management of that. And I can also help with that.
I think I missed that one. So coughing and with taking medications, is that?
So maybe we'll answer twofold. I'll say just from a standpoint of if water's exacerbating your cough, make sure you talk to your physician about aspiration. So the question would be if it was not related to interstitial lung disease, if there's something else that could be causing it. But let's maybe talk to Dr. Farrell with if it is due to underlying interstitial lung disease, sort of what would your recommendations be from a medication management standpoint?
Well, that's a bit tough to answer without knowing a lot about, diagnostic information, things like that. So I would imagine that you're seeing a pulmonologist. So I would say that, a full evaluation, mycophenolate mofetil Cellcept is one of the first line options we use in interstitial lung disease. So that would be probably the first choice. But again, like a full pulmonary eval would be really important, I think. Swallow test too, to make sure that it's not, from an aspiration issue either.
Thank you so much. And then there's another question regarding diarrhea. Does diarrhea improve after a longer term course of OVEV? So that's for you too.
Yeah, so this is kind of tough because I personally don't have as much experience with it. I did, speaking with the National Jewish Health Providers in Denver, they've been using it a lot, and according to them, so anecdotally, some patients do develop tolerance to it. I think it can also depend on all the other medications the patient's specifically on. So we know that Cellcept also can cause diarrhea, but I see it, some patients don't notice it at all, and then others have very severe diarrhea. So it's really hard to predict. So I think it's worth a try. I think with other medications, sometimes we will try a lower dose. I can't remember off the top of my head how OVEV is dosed, but or doing every other day dosing and seeing if that can help you build tolerance to it. And then, with food, without food, certain types of food, like paying attention, like doing a food diary of when you start the medication to see if any of those foods, like changing them, affects your ability to tolerate the medication too. So it's a lot of trial and error, as you guys know. But I think those are some things that are worth trialing.
Thank you so much. Great answer. And Rachel gives a shout out to the book, The Angel and the Assassin. So I want to make sure people saw that in the chat. Also, there was an exchange about if you wanted to be on the list of the Rocky Mountain Scleroderma chapter so that you can get information, or the Scleroderma Foundation local meeting in systemic sclerosis in Salt Lake. Please contact Rachel and she will help you get plugged in with our talks. Now, there's another talk for you, or another question for you, Jessica. I'm sorry, you're on the hot seat today. Normally, patients taking 3 pills of Cellcept in the morning and night for ILD, and she believes that last dosage is causing her to have insomnia. And this is a common, of course, complaint with patients. Do you have some suggestions what she can do to space her dosages? Yeah, so, okay, so you take the 2 in the morning and then 1 at 8 p.m. So is that? Oh, sorry, 3 pills. No, it's 1.5 grams. So 3 in the morning, 3 at night. So, I'm sorry, I lied to you. 1 daily. She's taking it daily. I am reading this wrong. Yeah, that's okay. So I would really just move that 8 p.m. dose up to like late afternoon. So roughly, so in other diseases, it can be dosed every 8 hours. So I'm not sure in terms of,
in the clinical trials used for, mycophenolate in scleroderma patients, exactly what times they required patients. Usually there's a window. So I would say move that 8 p.m. dose up until, it could be like 3 p.m. and see if that helps. I don't know. Tracy, do you have other suggestions?
No, that's absolutely right. Moving it up in the day is okay. It's not dangerous, but most of our data, of course, is driven by those windows where there was certainly a 12-hour window recommended. I think it was 8 hours was the slowest, if I remember off the top of my head, on the literature. So if you're taking your doses first thing in the morning and you wait out 8 hours later, that would be totally a great way to try to battle that. I have had patients who have taken that just, I think you're doing 2 in the morning. You could do 3 in the morning if that's okay with your physician. So that's sort of the caveat there, is talk to your physician. On these forums, we can tell you sort of what the data shows and how you can navigate it. But the most important thing is your prescribing physician agrees and is willing to prescribe it that way. But again, all 3 pills in the morning and is also another way you can get the dose in, and that's first thing in the morning. Yeah. And then also, just a plug for maybe Rachel's exercise program. It's really important that you realize the best time in your day to exercise so that you sleep well. So that's something you can certainly add to your regimen, I think is very valuable. And then there's another question about CBG being marketed as an anti-inflammatory, and is that true for scleroderma?
Yes. Okay, so CBG, the benefit with CBG is that it's very similar to CBD in a lot of ways. So it is not psychoactive, so we really do like that. It's a competitive antagonist at CB1, so it doesn't necessarily, it's not on my no-no list, like high THC products. And it binds similarly to CB2 as CBD. I don't have enough data yet to say whether I prefer CBG over CBD. I do know that the products with CBD that are available through Enhanced Clinical Nutrition, I know some of them do hit CBG as well. But in the grand scheme of things, I prefer to go with what's more known and what has more data and what I've seen more patients on. So I usually prefer CBD over CBG.
Great answer. And then there's a question regarding advice on IVIG effects on lung involvement.
So I guess that'd be for me too, right? IVIG is a tough one. So IVIG has been studied in so many different conditions, and there's so many different dosage versions of IVIG, so brands of IVIG. So currently I know that there is a very specific IVIG brand that's being studied in scleroderma lung disease. So I think because I'm not familiar with some of the older studies with different versions of IVIG. So I think that's the limitation, is because when you prescribe IVIG, there are lots of different brands, and sometimes depending on the hospital or institution, you're not allowed to pick a specific brand, also because of availability too. So I think that tends to be the limitation. That doesn't really answer the question, but I think I would look out for some of those studies that are going to be coming out with the brand that's being studied specifically for scleroderma ILD.
There's another question for you, and it was in the question and answer session, and it says, hello, I just started taking OVEP. How long should I wait to take the mycophenolate? Sorry.
Go ahead. So in terms of, I'm assuming it means in terms of dosing. So if in terms of timing, so if you're able to take the mycophenolate first thing in the morning, OFEDs, I think, is supposed to be taken with food, and I think it is specific to be 12 hours apart. So I would say, I don't think there's a problem taking them together, but if taking the mycophenolate, I'm assuming that you're likely on a proton pump inhibitor also. So if you're able to take the mycophenolate first thing in the morning, and then wait 90 minutes to take the proton pump inhibitor and also taking the OFEV at that time. I think that's reasonable if it works with your day. Oh, and I think that okay, so Sarah had a great question about hydroxychloroquine, and I answered it. It was in the Q&A box instead of the chat. So hydroxychloroquine, so COVID, unfortunately, has really been so impactful on our treatments because it's being used as treatments for many different drugs are being used for, investigational treatment for COVID patients, and they're being used differently than they're used in rheumatic disease. So hydroxychloroquine is one of the ones that this was so sad to me when this happened because hydroxychloroquine has been one of our staples in rheumatic disease, especially lupus patients. And the use in COVID caused drug shortages. It caused so much media related to side effects and safety concerns. And, patients stopped taking it because of the media. So one very important piece of information that was presented last year in November at the American College of Rheumatology conference was a large study that looked at patients taking hydroxychloroquine at doses less than 400 milligrams or less, which are the doses we use in rheumatic disease. They used much higher doses in COVID patients. And they looked at whether there was an increased risk of heart-related problems in the patients taking hydroxychloroquine compared to the matched people that looked very similar that weren't taking hydroxychloroquine. And this was a very well done study, and they did not find any increased risk of heart-related issues with hydroxychloroquine in our patient populations on the doses that we use. So I think that is so important. We've been using it for years and for many decades. And this would have been a safety signal a long time ago if it was a true safety signal for our patients and our doses. So that's one of the things that I mentioned and I wrote back in the Q&A section. Hydroxychloroquine has been studied for so long that there is lots and lots of safety and efficacy data, like I mentioned, specifically in lupus patients where, studies that have shown decreased negative outcomes like, hospitalization and death. And even in pregnant lupus patients, there's data to support that can protect the baby during the pregnancy. So, it's hard not to listen to the media, but I think it's all in context too. So, sorry, I'm off my rant.
I also wanted to add too that we're learning more and more, and as I go along, more of an alternative or complementary medicine pathway here with traditional Western medicine as well. The combination of the two knowledges brings in the idea that hydroxychloroquine may actually be treating some underlying infection that hasn't been treated before, or could be one of those indicators or causes to make the scleroderma worse. So we don't have a good mechanism of action, but we know that it works really well in a lot of patients with minimal side effects. So that's what I had to add. You did a great job, Jessica. Thank you.
Oh, absolutely. Important questions. So we really appreciate everyone staying on here and allowing us to make sure everyone's questions are answered. I might, though, turn it back over to Rachel here. But before I do, I'm just going to check the question answer again. It looks like everything has been answered that's been asked. I just want to again thank all of the speakers in not only this session, but all day. In my opinion, one of the most high quality Scleroderma Foundation talks I've ever had. And the reason I think it is so wonderful is because we have such passionate providers and passionate patients, and together we can really make a difference. And so thank you for joining us today. A special thanks to the national sponsors, Janssen, Boehringer Ingelheim, I always have a hard time saying that, BI, and Horizon Pharmaceuticals.